Let's talk about ectopic pregnancy. You know, for centuries, it was one of the most feared and often fatal complications in early pregnancy. It was a condition that could be a death sentence. But over the last few decades, a quiet revolution in medicine has totally transformed how we diagnose and manage it. This is a story of some pretty incredible medical progress.
Okay, so let's just dive right in. To really get what's changed, we have to start with the most basic question. What actually happens when a pregnancy starts to grow in the wrong place?
Well, it's called an ectopic pregnancy. That word ectopic literally just means out of place. So instead of implanting inside the main uterine cavity, where it has plenty of room to grow, the embryo attaches somewhere else. And as you can see here, most of the time, that means inside one of the fallopian tubes.
Now look, this is absolutely a serious, potentially life-threatening condition. But the story we're exploring here isn't one of fear, it's really one of hope. A true revolution in our ability to see what's going on inside the body, and the new strategies we have to manage it have completely rewritten the ending for patients.
So let's start by really understanding the stakes. What exactly are we talking about, and why is this condition taken so seriously?
So the clinical definition is pretty straightforward: a pregnancy developing outside the main uterine cavity. The reason it's so dangerous really comes down to this term you see here, hemorrhagic morbidity. That's the medical way of saying there's a risk of severe internal bleeding, and that is the #1 threat.
So where does this usually happen? Well, this number is just staggering. Somewhere between 95 and 97% of all ectopic pregnancies happen inside the fallopian tube. This is the classic type that doctors have been focused on for more than 100 years.
And this really gets to the crucial point. The real danger, as the source material puts it, lies in the unknown. An ectopic pregnancy that goes undiagnosed can rupture and lead to incredibly severe complications. And that's why the ability to find it early is such a game changer.
Which brings us right to the first part of our story of progress, the diagnostic revolution. I mean, how we find these pregnancies has changed in ways that would have been completely unimaginable just a few generations ago.
This timeline really tells the whole story. Historically, and it's grim but it's true, the diagnosis was often made after a patient had already died. By the middle of the 20th century, doctors could step in with surgery, but typically only after a rupture had already happened. But today? Now we have high-resolution transvaginal ultrasound, which means we can often literally see the ectopic pregnancy long before it ever becomes a crisis.
And this is the power of that modern imaging in action. In expert hands, we're talking about nearly 8 out of 10 ectopic pregnancies being positively identified on the very first scan. That has shifted the entire approach from emergency reaction to proactive, thoughtful management. Now, while we know most ectopics are in the tube, that's not quite the whole story. It turns out the location can be more complex, and understanding all the different types is absolutely key to modern treatment.
You can almost think of this as a map of the possibilities. Ectopic pregnancies are put into two big groups. First, you have the extrauterine pregnancies. Those are located completely outside the uterus. And then you have uterine ectopics, which are actually inside the uterine structure, but just in the wrong spot.
So let's break that down. The extrauterine ectopics, those are the classic ones we've known about for a long time. Tubal, ovarian, even abdominal. But what's really fascinating and a growing challenge is the second category, uterine ectopics. These are pregnancies implanting in places like a C-section scar, the cervix, or even deep inside the uterine muscle wall itself. And the difference is pretty stark when you see them side by side. On the left, there's your classic tubal ectopic, clearly outside the main body of the uterus. But on the right, you can see a pregnancy that is implanted right into the scar from a previous C-section. It's inside the uterus, but in a very dangerous location. So you're probably wondering, why are we seeing more of these? Well, it's a direct consequence of another medical trend. As cesarean sections have become more common all over the world, it's created a new anatomical site, that scar tissue, where a pregnancy can mistakenly implant. And that has led to a rise in this very complex type of ectopic pregnancy. Okay, so we can find them and we can classify them. This brings us to the most important part. What do we do about them? This is where the whole approach has shifted from just do surgery to a much more nuanced strategy. Right. The goal today isn't just to resolve the pregnancy, it's to do it in the least invasive way possible.
The source material really emphasizes avoiding overtreatment and harm caused by the treatment itself. The focus is on safety, of course, but also on preserving a patient's chances for a future, healthy pregnancy.
What's so crucial to understand is that there is no one-size-fits-all solution anymore. There are three main paths. For very small, failing pregnancies, sometimes the best approach is just expected management, or watchful waiting, to see if it resolves on its own. For stable patients, medical management using a drug called methotrexate can often stop the pregnancy from growing. And then for emergencies, or when other methods just aren't a good fit, there's surgery, which today is almost always minimally invasive.
And even within surgery, there are big choices. A salpingectomy removes the entire fallopian tube. That's the standard treatment, and it eliminates the risk of any tissue being left behind. But then there's a salpingotomy, which is a more conservative surgery. It opens the tube, removes the pregnancy, and then preserves the tube itself. Now, it comes with a small risk of needing another procedure, but it's often chosen to help preserve fertility. It's a really critical trade-off that patients and doctors have to discuss.
And finally, treatment is not the end of the journey. The experience of an ectopic pregnancy has long-term implications, and modern care is increasingly focused on caring for the whole person. After an ectopic pregnancy, there are so many things to consider. Patients worry about their future fertility. There is a higher risk of it happening again. The source puts that somewhere between 5 and 19%. Planning for the next pregnancy requires a lot of care and monitoring. And, so importantly, there's often a need for psychological support.
We really can't overstate this. An ectopic pregnancy is not just a medical event, it's the loss of a pregnancy, and it's often combined with a medical emergency. It can be a deeply traumatic experience, both physically and emotionally.
And this quote really captures that evolution in care. The source material explicitly calls on clinicians to recognize the psychological aftereffects and the real need for emotional support. It's a clear acknowledgement that healing goes way beyond just physical recovery.
Which leaves us with a final thought. The story of ectopic pregnancy is a huge triumph of technology, of research, and of skill. But as our medical abilities continue to advance at this incredible pace, it also reminds us to ask a really crucial question. How do we make sure we're always treating the whole person, not just the condition?